All attendees are in listen-only mode.
Good afternoon, and thank you for joining us for today's webinar, Panethnic Carrier Screening, What to Order and When. My name is Derek Stevens, and I'm the Director of Marketing here at EGL. I'd like to introduce our first presenter, Dr. Alice Tanner. She is board certified in genetic counseling and clinical molecular genetics, and is currently a laboratory director in our molecular lab. Dr. Tanner has been at Emory Genetics Laboratory for the past 10 years, serving at various times as a clinical genetic counselor, laboratory genetic counselor, and laboratory director. Our second presenter is Dr. Christin Collins. She completed her clinical molecular genetics training at Harvard Medical School and is board certified in clinical molecular genetics. Dr. Collins has been a laboratory director in our molecular laboratory for the past 5 years. Dr. Tanner.
Thanks, Derek. Hi, everyone. As Derek said, this is Alice Tanner, and I'm going to start off the webinar today. Before we get started, I just want to give our disclosures, just to make sure everybody is aware. Christin and I are both lab directors at Emory Genetics Lab, and our lab does fee-for-service testing, and that includes Panethnic carrier screening. So now everybody knows that's out of the way. The objectives for this webinar, we want you to understand the need for Panethnic screening panels, to realize the importance of pre-pregnancy screening, and to discuss the options for follow-up of positive screens. So why carrier screening? As you all probably know, regardless of your ethnic background, we're all carriers of multiple recessive diseases. And some of these diseases have the potential to cause severe and potentially life-threatening diseases in our offspring. And the risk for carrying a mutation in a particular disease gene might be increased based on our particular ethnicity. But the risk for carrying a mutation in another gene may not depend on our ethnicity at all. But carrier screening can provide us with knowledge about ourselves and with knowledge of our reproductive options. This is a graph of some approximate carrier frequencies based on ethnicity for certain diseases. And you can see from this graph, this table, that there are certain diseases that have increased risk in certain populations. So you could see, for instance, sickle cell disease has a higher carrier frequency in African Americans and people of Mediterranean descent. And things like Gaucher disease and familial dysautonomia are elevated risk in people of Ashkenazi Jewish descent. Then there are at elevated risk in people of all of the populations in this table, but the risk differs by ethnicity. So for cystic fibrosis, for instance, that's listed under all of these populations, but the carrier frequency differs depending on what ethnicity you are. And then there are some diseases which just the general population at a whole seems to be everybody at the same risk for being a carrier. And these are things like spinal muscular atrophy and Fragile X syndrome, excuse me. So given these risks for being a carrier, what should we do about carrier screening? So there are some professional societies that have made recommendations on carrier screening. Mainly these societies are the American College for Medical Genetics and Genomics and the American Congress of Obstetricians and Gynecologists, or ACOG. So for cystic fibrosis, for instance, the ACMG recommends offering testing to Caucasians and Ashkenazi Jewish individuals and making testing available to people of other ethnicities. And they recommend that along with this testing, you should offer education about detection rates and informed consent to make sure that individuals understand that this is carrier screening, and a negative screening result doesn't necessarily mean that you are absolutely not a carrier, and that the detection rate is going to differ depending on your ethnicity and the test that you're doing. ACMG also created a panel of 23 mutations that they recommend be screened for. And these mutations, the way they were chosen is that they are all at an allele frequency of greater than 0.1% in the general US population. Now, because most of the individuals with CF in the US population are Caucasian or Jewish, most of those alleles on the panel are alleles that are at high frequency in individuals that are Caucasian or Ashkenazi Jewish. So this panel has very high detection rates in those individuals. The detection rates aren't quite as high in individuals of other ethnicities, and so that's something to keep in mind. ACOG originally recommended offering CF screening by targeted mutation panel to Caucasian women and Ashkenazi Jewish women. But in 2011, they updated their guidelines, and they now recommend offering CF carrier screening to all women of reproductive age, and not based on ethnicity. And this is because of increases in mixed ethnicity and difficulties in determining ethnicity. For people of Ashkenazi Jewish heritage, ACOG recommends offering screening for 4 diseases, and these are Tay-Sachs disease, Canavan disease, and familial dysautonomia. ACMG recommends offering carrier screening for those 4 diseases and 5 others, and these include Fanconi anemia C, Niemann-Pick A, Bloom syndrome, ML4, and Gaucher disease. For SMA, which is in the general population has a carrier, has a risk of being a carrier for SMA, ACOG does not recommend general population carrier screening at this time, but ACMG does. They recommend offering carrier screening to everyone regardless of race or ethnicity. And then ACMG recently released some guidelines for considering which disorders should be included on a panethnic carrier screening test. So based on these recommendations, all you have to do is ask your patient what her ethnicity is and then test her for those ethnic specific conditions, add on the ethnicity independent conditions, and you're good. That's easy, right? Not really. So let me ask you a question. What ethnicity are you? If I ask you that, can you tell me right now what ethnicity you are? Are you sure? How far back can you really trace your pedigree? Most individuals can probably go back 2, maybe 3 generations, and then after that, they're really kind of relying on hearsay. You know, people have family stories. Everybody knows the story of so-and-so, the ancestor from 5 generations back who had, these great tales of heroics that happened, and but nobody really knows exactly if that was true or what ethnicity that person really was. And in addition to all those family stories, we probably all also have a lot of family secrets, and you may not even know you have a family secret. That's why it's a secret. But some examples of these could be families that had to hide their Ashkenazi Jewish heritage during World War II. There are also examples of African American families that had to hide their African American heritage in the American South in the past few hundred years. So you can't really know whether or not you have family secrets or not, and so you can't really know if you are absolutely sure that you are the ethnicity you think you are. And you may be missing some ethnic background that you don't know you have, or you may just be wrong. And you've probably seen the Ancestry.com commercials where individuals thought they were one ethnicity, and then they had the Ancestry.com test, and it turns out they were another ethnicity. So determining your ethnicity is not really as easy as people seem to think it is. And along the same line, studies have shown that people really don't know their ethnicity. Even if you ask them, a lot of people will say that they don't know. As a genetic counselor here in Georgia, I know I have had many times when I've been asking people about their ethnicities, and they'll just say, oh, we're from Georgia, or we're from Tennessee. And that's about as far back as they know. They don't know what happened before they came to America. And then other studies have been done where people will give their ethnicity, and then they have genetic testing done, and it turns out the ethnicity that they give is not the same as the genetic backgrounds that they come up with. So because of this, and because ethnic admixture is increasing, there's a need for panethnic carrier screens. So in addition to that ethnic admixture that's increasing, technical costs recently have been dramatically reduced, And multiplexing for large numbers of mutations at once is now possible. And this has made it possible to screen for multiple conditions at once cheaply, and quickly. So we can now offer pan-ethnic carrier screening to the general population regardless of ethnicity. This also reduces the complexity of carrier screening because you don't have to have a different algorithm for different patients. You don't have to have a different set of tests for a different subset of individuals. And pan-ethnic screening this way is also more equitable, which means everybody gets screened for everything. You can detect everything in everyone. And this is also a reason why newborn screening, for instance, is not ethnicity based. We don't only test African American newborns for sickle cell and Caucasian newborns for cystic fibrosis. So kind of using that newborn screening model, that also makes sense in carrier screening as well. So what mutations or conditions should you include in a pan-ethnic screen? There are lots of options. At EGL, we started with the recommendations from the professional groups. So we started with the recommendations from ACMG and ACOG. We also started with our own history. EGL has a very strong history of providing molecular testing for newborn screening follow-up for Georgia and for other states. We also have a history of testing for lysosomal storage diseases and other metabolic diseases as well. So we used all of that expertise and our database of mutations that we have grown over time to include mutations for all of these early onset severe conditions. Some labs also include an option for milder conditions or for X-linked conditions. And labs can also include pseudodeficiency alleles. And the reason for including these pseudodeficiency alleles often also goes back to newborn screening. So while these aren't going to cause disease in their children, they may cause abnormal newborn screening results or other abnormal biochemical results. And so this is information just to let the parents know if the newborn screen is positive for this disease, it may be because of this pseudodeficiency allele. So now Kristen's going to talk about how some labs might put these options together and present these as actual tests.
Thank you, Alice. So I'm here to talk a little bit about the testing options that various labs have for carrier screening and the types of approaches to this testing. So as Alice mentioned, pan-ethnic carrier screening is certainly one viable option, and I think she's provided some evidence for why it's a truly relevant option for most patients. But that's not to say that there aren't ethnic-specific panels as well. So there are some laboratories offering hemoglobinopathy panels for individuals of African descent and still offering Ashkenazi Jewish specific panel for individuals of Ashkenazi Jewish heritage. In addition to just these panels that help you decide what disorders are included on the testing, there's also the decision of whether you want targeted testing versus gene sequencing. When you're doing targeted testing, you're looking for known pathogenic changes in the genes that are causative of the disorders on your panel. Many times these pathogenic changes are common in specific populations, or they're known pathogenic variants that have been identified in the laboratory that's doing the testing. So as Alice mentioned, we have extensive screening or testing history for metabolic conditions. So many of the known pathogenic changes that we've identified in those metabolic genes are included on our pan-ethnic carrier screening. When you're thinking about gene sequencing will detect all the variants in the gene, the benign variants, the pathogenic variants, as well as the variants of unknown significance. And it's really up to you as a healthcare provider to discuss with your laboratory that you're interested in using to see what their policies are. Do they report the variants of unknown significance, or are they just reporting the pathogenic variants? If you don't want variants of unknown significance to be reported, you need to consider that when you're choosing a laboratory to offer your testing, or to send your testing to. Here at EGL, we essentially have 3 carrier screening options. So we have the pan-ethnic carrier screening, which is really intended to be our comprehensive screen for individuals seeking carrier testing. So this includes the most comprehensive list of disorders that we have. We also do Ashkenazi Jewish carrier screening, which is a sub-panel or a smaller panel of the Panethnic carrier screen. And this is really intended for individuals of Ashkenazi Jewish heritage or ancestry who are not interested in expanded screening. So these are those conditions that are recommended by the ACOG and the ACMG to target for the Ashkenazi Jewish population. Lastly, we have what we call the ACOG or the ACMG carrier screen. And this is really intended for individuals who just wish to test for those conditions that are specific to certain ethnicities as recommended by the ACOG and the ACMG. This includes CFTR and SMA and some of the Ashkenazi Jewish subpanel disorders. So that really is the three flavors that we have as far as the diseases that we're testing for, the disorders that we're testing for. And then you can choose whether you want to do the targeted mutation testing, which is just looking for a predefined list of known pathogenic changes. Or you want to do the sequencing option, which detects all the variants in the gene. However, our laboratory only reports the known only reports pathogenic variants and likely pathogenic variants. We do not report variants of unknown significance for this testing. That said, you can imagine that there are some conditions for which there are private pathogenic variants, so nonsense changes, frame shift changes that are not common in the population and may not have been seen before, and therefore would not be put on a panel, that you're ordering as for a targeted mutation testing. And so that's where the benefit of a sequencing option would be good. And specifically if you're targeting populations that are less common. So if you're thinking as far as information known about that disorder, so you're thinking Southeast Asian, Middle Eastern, there's less known about what we can find in those genes as opposed to a Caucasian or an African American population. So that may be something to just consider when you're sending testing for your patient. Here at EGL, this is a list of the various carrier screening options that we have. We have the Panethnic carrier screen as well, both for full gene sequencing and targeted mutation testing, the Ashkenazi Jewish screen, full gene sequencing, targeted, and then the ACOG ACMG. But one thing I just wanted to draw your attention to here is that this carrier screen is more than just sequencing. There are a number of different disorders that are tested for that can't be detected by sequencing. So we also offer Fragile X repeat analysis as part of this testing, spinal muscular atrophy deletion testing, targeted arrays for DMD, MECP2, and CFTR, and as well as targeted alpha thalassemia deletion testing. And so not all versions of not all tests have all of these sub-panels or sub-tests. So Fragile X is only offered for individuals who are ordering the Panethnic carrier screen and the Ashkenazi Jewish, but not offered for the ACOG ACMG since it is not currently recommended by that organization. Here's an example of what a report from EGL for our Panethnic carrier screen targeted mutation testing would look like. Here you can see this is the front page of our report, and it's basically a summary of the results that we had identified. And we've really tried to make these reports patient-friendly. So even though medical professionals are ordering this test, eventually we assume that the medical professional will be handing the report to the patient. And we'd like to make it as easy for the patient to understand what their results are and that it can travel with them. So if they change physicians or they want to pass their information along to their families, they can tell everybody what's in their report. And we subdivided things between what we found in autosomal recessive carrier screening results, X-linked carrier screening results, your Fragile X results, your SMA, and then what we've called other findings of note. These other findings of note are those typically milder or conditions or the pseudodeficiency alleles that Alice mentioned earlier in the talk. And I'll talk a little bit more about this in another slide. But you can see for this particular individual, they're a carrier of a change in the CFTR gene. This actually is the delta F508 change. And then they also have a negative X-linked carrier screening results, normal Fragile X repeat alleles, and then a negative SMA result, and a number of other findings of note. If we were to dial further into the report, you could see here information about their cystic fibrosis result. And I mentioned that this report was written to be patient-friendly, and so the language is written to be able to be understood by your patients. And here you can see that the patient is a carrier for the C.1521-1523 deletion CTT, which is the delta F508 change. In addition to indicating information about this change, we also put current reproductive risk. This is giving you the risk of what your reproductive risk would be if your partner is untested, if your partner was tested in our lab and is negative, or if your partner is a carrier. So we're doing some of the work for you up front so that you can provide that information to your clients. Under the other reportable results section, there were a number of results for this patient, but I've just detailed one. And you can see here is the galactosemia Duarte variant was identified in this patient. And this basically is not a disease-causing mutation. Many of you, I'm sure, are familiar with the Duarte variant. And this variant really causes a decrease in the amount of enzyme, but doesn't cause disease. This is a common variant that will trip a newborn screen for a positive. And so it is not uncommon for individuals with Duarte to have positive newborn screens. And so basically this information would be useful for someone who had a child who had a positive newborn screen for galactosemia, and it might reassure them a little bit while they wait for the follow-up testing that perhaps this is just my Duarte variant that's causing these results in my child. It may not be, but that is reassuring. In addition to positive findings, we also include residual carrier risk for conditions for which the individual tested negative. And so you can see here just the first page of our residual risk section of the report. And you can see for this individual, the prior carrier risk pre-test, and then the residual risk post-test. And the residual risk is calculated based on the prevalence of the disorder in the population that the patient is, as well as the detection rate for this test. And again, we're doing some of this work up front for you. And this is information that a lot of genetic counselors like to provide for their clients because this is a screening test. You are decreasing the risk, but you're not necessarily making and communicating to the patient that the risk is 0. And I had mentioned that for our testing here at EGL, we had a number of different types of tests that were included in the panel, like I mentioned, Fragile X and SMA. And it sort of brings to the point that NGS isn't everything. You really need to be careful to check the methodologies of the tests that you're ordering, and making sure that the methodologies being used are appropriate for the test or the disorder that's being tested for. So NGS alone is not sufficient for testing for some of the common disorders. Genes and disorders with highly homologous regions or pseudogenes. Sanger sequencing has been the gold standard in the past for disorders such as GBA for Gaucher disease and BWF for von Willebrand factor. I will comment that there are advances in strategies for laboratories that are getting around this and able to develop some techniques that can be used for an NGS for these homologous regions, but not everything. And you certainly want to make sure that the laboratory that you're sending your samples for has at least considered this and is able to handle this problem of the pseudogenes and homologous regions. Additionally, there are disorders with large deletions, SMA, alpha thalassemia, Duchenne muscular dystrophy. This really isn't at this time able to be tested for by next generation sequencing. So you need complementary tests like MLPA or ACOG technology. And our laboratory uses both of these for these testings. There are also disorders that are due to triplet repeats like Fragile X syndrome, which need TNR trinucleotide repeat analyses. And so this is not something that would be done by NGS. And you just need to be mindful that while next generation sequencing has been incredibly useful diagnostically in detecting and screening for large numbers of genes for various disorders at one time, it doesn't do everything. And if you want to have a comprehensive test, you need to make sure that the methodologies and the disorders that you're interested are included in your panel. So you've run your panel, you've decided you wanted a particular type of carrier screening. and you found out that your patient is a carrier for a recessive genetic disorder. So what's next? You know, how do you go, where do you go from there? So the next step is testing of the partner. And what kind of testing should you order? Should you order a panel, or should you do gene sequencing? And this is really sort of where you need to have conversations with the family, and you have conversations with you know, what the intention is here. If you have an individual who is a positive for a CFTR gene mutation for cystic fibrosis, and their partner is Caucasian, then doing targeted testing may be appropriate, because the detection rate for targeted testing in that population is quite high. But if they were Asian, you may want to consider the gene sequencing option, because the detection rate for CFTR panel testing in Asian populations is lower. And then you also can consider potentially other findings that are coming up with the gene sequencing testing. So if you're doing targeted gene sequencing for the CFTR gene, you will likely or possibly get a variant of unknown significance. How are you going to consider that? How is the family going to be able to process that information? And so that's all stuff that needs to be considered when you're thinking about testing the partner. And you know, other things to consider for follow-up testing are adoption, sperm donors, egg donors. Do you want to consider pre-implantation genetic diagnostics for the known parental pathogenic variants? Or perhaps you would prefer to do prenatal testing, or invasive prenatal testing, CVS or amnios, for the targeted molecular testing of the parental pathogenic variants. So you can choose to do CVS for the 2 CFTR pathogenic variants that you've identified in the parents, and make decisions from there. And we talked a little bit about, you know, in the intro, about making sure to consider the importance of preconception genetic screening. And I really would argue that the most important reason that you should consider preconception screening is time. You know, if you have time to make decisions, you have time to think about how you want to test the partner. The family and the couple have time to think about what kinds of prenatal testing, if any prenatal testing, they want to do. They have time to consider other options for family planning. Perhaps they want to do adoption, or perhaps they want to do egg or sperm donation. And then, you know, it also allows individuals to identify appropriate medical specialists for both the mother and the fetus, pre-pregnancy and post-pregnancy, excuse me, during pregnancy or in post-pregnancy. So there's really, you know, the ability to discuss and make decisions without the sort of looming pregnant, you know, timeline that you have once your patient is pregnant. So we are here talking about carrier screening, but I want to just make note that diagnostic findings are possible for carrier screening. And this is really relevant when you have disorders that can present as severe childhood onset, but may also have milder forms, such as Gaucher disease and Wilson's disease. And it's really especially important to consider this if you're choosing a panel that includes milder or more variable condition. This is really a fine line between testing for everything, which some individuals want, and then balancing that with the unexpected findings. And you have to do pre-test counseling to really let the couple know that this is a possibility. And it's certainly been a possibility here at EGL. I'm going to present a couple of case studies here where we've run carrier screening and identified diagnostic findings in patients. So this first one here is a 36-year-old Asian female who was referred to our laboratory for Panethnic carrier screening. They chose the full gene sequencing option. And this individual was found to have 2 variants in the ATP7B gene, which is causative of Wilson's disease. And if you can see here, this is a graphic of the next generation sequencing reads that we have. And you can see here, this is the reference sequence, or the reference or the wild type sequence. And then in the bottom is the consensus sequence, which is the patient sequence. And you can see here that at this coding position, 3664, there's a deletion of a G. This is actually in the opposite strand, so it looks like a deletion of a C, but trust me, it's a deletion of a G. And then over here at coding position 3646 is a change from a G to an A. Again, this is the opposite strand, so it looks like a C to a T. And the interesting thing about this particular case is that the reads were close enough that we were able to determine that these variants were on opposite chromosomes. So that indicates that this individual has these two changes, one of which is pathogenic and one of which is likely pathogenic in trans. So this would be consistent with the diagnosis of Wilson's disease in this patient. We subsequently followed up with the healthcare provider, and they confirmed a previously established diagnosis of Wilson's disease in this patient. So we were able to breathe a sigh of relief, and yes, this is something that is not completely surprising to the provider. However, we have another example where we had a 31-year-old Caucasian female who was referred to our laboratory for targeted mutation panethnic carrier screening. And she was found to have a pathogenic variant and a likely pathogenic variant in the DHCR7 gene, which causes Smith-Lemli-Opitz syndrome. And this syndrome can be milder and have later onset, sort of presentation. Subsequent follow-up with the healthcare provider, however, indicated that this individual had no significant personal medical history or family history. So this was a bit of a surprise to this provider. Biochemical testing and targeted testing confirmed segregation was recommended for this patient. And so right now we don't know if these changes are on the same chromosome or opposite chromosomes, and so parental testing could help with that. And then lastly, we have a 27-year-old Ashkenazi Jewish female who was referred for targeted mutation analysis for our panethnic carrier screen. And I mentioned to you here at EGL that we do targeted DMD, CFTR, and MECP2 deletion and duplication testing by array CGH. And the way that a targeted array CGH works is you still need to have some probes across the backbone of the entire genome for normalization of your data. And so because of this, we are able to detect a chromosomal imbalance in this individual. It was a 4.2 megabase deletion on the long arm of chromosome 18 from band Q22.3 to band Q23. Similar deletions of this chromosome have been reported in individuals with cognitive impairment, brain dysmyelination, kidney malformations, and oral atresia and short stature. When we followed up with the healthcare provider, they indicated that this individual was a university-educated female with no significant personal medical history or family history. And that we recommended at that point that the parents be tested to see if this was de novo finding or if this was inherited. And this could be an example of reduced penetrance and variable expressivity. But it really highlights, these three cases really highlight that the need for pre and post test counseling for carrier screening. And it's important to address the complex genetic issues such as diagnostic findings that could be identified, variable expressivity, and reduced penetrance. And really also, I believe, highlights that professional involvement is necessary to ensure patient understanding of their clinical results. These are complicated topics, making sure that your patient really understands that they could have this finding but not have the disease, and yet have a child who has the same finding and could potentially have the disease. And so really you need to have a genetic counselor or healthcare professional involved to talk about these things. And this may be why direct-to-consumer testing may not be a great idea for your patients or for your individuals. The other thing I kind of want to stress here is that providing appropriate clinical information to the laboratory is really important. Even though you're looking at healthy individuals, if there's anything that can flag as a potential information that could be useful in interpreting data, it really helps us provide the most accurate interpretation of the results so that you get the best report that you can get. And so lastly, I kind of just want to plug why EGL, why you should consider sending testing like this to EGL, is that we can do everything in one laboratory. So we can do the carrier testing here, and that includes your couple. And then we can do the prenatal testing. So your couple has been found to have each be a carrier of a pathogenic variant. We can then do the prenatal testing on the invasive sample, so the CVS or the amniocyte sample. Or we could do the testing postnatally, We can also do carrier testing on on family relatives and testing other individuals in the family who may now be at risk to be carriers based on your patient's results. And so this is all information, all things that can be done in one laboratory, and then we would have the information, the history of the whole family, just to help with this testing. Okay, and so lastly, just want to acknowledge everyone here at EGL and all the help and work that they've done in collecting this data. And then I guess now just open the questions here. Yeah, so we have a question here that says, if Panethnic carrier screening shows a patient is a carrier, I prefer testing the partner using sequencing plus del-dup, not sequencing only. What is the practice here? And I'll answer that first. And yes, for almost every gene on our panel, we have a sequencing assay as well as the deletion duplication test. And so I agree that that would be the best approach as far as capturing the entire mutation spectrum of the disorder. But you may also want to think about what the mutation spectrum is for that disorder. Is deletion duplications an option? I don't know if you want to comment as well.
Yeah, I mean, I would say the same thing. For the patients that you have that want everything and want to be sure that they have double checked everything, that would be the way to go. We have deletion duplication testing for the genes that, almost all of the genes that we have sequencing for. So that would make sure that you dotted all your I's and crossed all your T's. If, however, there has never been a deletion or duplication reported in that gene before, you have to weigh kind of the cost versus the benefit you're going to get. On the other hand, you also, the more testing you do, the greater your risk of getting a variant of unknown significance. So if you do a full gene sequencing test, we're going to report everything. So we will be reporting variants of unknown significance if you just do a single gene full gene sequencing test. And you can also get variants of unknown significance in deletion duplication testing. You can get duplications that have never been seen before that might be variants of unknown significance. You can get duplications in non-coding regions or in introns that might be variants of unknown significance. So, yes, it's available, and, if it was me personally, I would probably do it, but, you really need to talk to your patient and see how much tolerance they have for variants of unknown significance and uncertainty.
Okay, that looks to be the only question that we have here. If there's anything else, we'll wait a few minutes to see if there's anybody else who has a question. If not, thank you for your attendance, and feel free to contact us if you have any further questions. Okay. Thank you very much.
Oh, wait, there's another one.
Oh, we actually just got another question in. I'm going to click on it.
Oh, no, it's the same question, I think.
Yeah, I mean, the second part of the question is just, are there different guidelines for genes known to be prone to deletion? I believe Alice answered that in answering the last question, and that there probably it's more what if you want to have, and if you have an individual who wants the most amount of information they can possibly get, you should be doing it, but weighing the risk of uncertainty and the cost for the family and what their sort of tolerance for that is. Okay, that looks like everything. Thank you guys very much for attending, and have a nice afternoon.